Hello everyone. Today we will be doing the USMLE test and discussion series of dermatology. Beginning with case 1. A 34-year-old woman comes to the office due to skin changes. Blotches of skin on her arms appear to be of a different color, and she also has a tingling sensation in her hands. These symptoms have developed over the past several months. The patient has no other past medical history. She is a political refugee from East Africa. On examination, there are patchy areas of skin anesthesia and hypopigmentation on her upper extremities. Nerve biopsy evaluated under light microscopy shows many organisms invading the Schwann cells. HIV testing is negative. Which of the following organisms is the most likely cause of this patient's condition? This is the photo of the patient, and these are your options: Borrelia burgdorferi, Corynebacterium diphtheriae, Mycobacterium leprae, and Treponema pallidum. So in the exam, when you come across such a question, or any question for that matter, you must use the highlighter option and mark the important points. For example, I will mark the important points in this question. Age and sex is important. You see that the site was arms. There was some kind of tingling sensation. Then you see that the patient was from Africa, East Africa. And what was the kind of lesions? She had patchy areas of skin anesthesia, and she had hypopigmentation over those areas, and these were on the upper limbs. And nerve biopsy was done, which showed organisms invading the Schwann cells. So putting all this together, what is your answer? So the correct answer here is Mycobacterium leprae. So Mycobacterium leprae causes a disease which is known as leprosy or Hansen's disease. What are the cardinal signs for diagnosis of leprosy? What is it in this question that makes you think of leprosy instantly? So you see, the cardinal signs of leprosy are any patient which presents with hypopigmented or erythematous macules with sensory loss, which is what this patient had. And there is presence of thickened peripheral nerves. So in the question they have told that there was some kind of involvement of nerves, and a nerve biopsy was done which showed involvement of Schwann cells. And the third point is a positive acid fast skin smear. So this is not mentioned in the question, but it is likely to be asked in the exam. So a slit skin smear is a smear which is done for the diagnosis of leprosy. Here we take a smear either from the earlobe or from one of the lesion, and we do Zn staining on it, and then this is seen on the microscope. So on the microscope you would see these kind of pink organisms which are basically M. leprae. These are either present discretely or these are present in clusters, and these are present on a blue background. So when you fit these all together, you see that both of these findings were there in your patient, which should let you think of leprosy instantly. So leprosy or Hansen's disease is a deforming infection, and it is caused by M. leprae, and the two sites which it involves, you should remember, are the skin and the nerves. Transmission is promoted in unhygienic condition, basically in those communities where they are living close together in unhygienic conditions, where a lot of people are living in one household. It is likely and it is very common, and in those areas where leprosy is endemic, there it is seen in more frequency, and the transmission occurs basically through the respiratory route. And some organisms can also be transmitted through prolonged direct skin to skin contact. Infection has also been associated with armadillo contact in the southwestern US. So M. leprae basically infects the Schwann cells. This is the first site which it involves. So it involves the nerves, and within the nerves it has predilection for involving the Schwann cells. It grows best at temperature below core body temperature. Partially this explains why it manifests in the skin and in the nerves, and then the other two sites where you can see are eyes and testes. So this is an example of a patient who presented with a hypopigmented macule, this first one here that you are seeing. And this macule has ill-defined borders. At places it is well-defined, and at places it is ill-defined. This was a hypoaesthetic macule, and when you see such a patient, instantly your first differential diagnosis should be leprosy. This was a patient who presented with well-defined erythematous to hypopigmented macules which had more prominent borders. And there were certain satellite macules which were present on the boundaries. So this was a case of BT Hansen's. which is the second one that you're seeing. The first one that you're seeing was a case of indeterminate Hansen's. This third case was a case of lepromatous leprosy. Here you are seeing that there are a lot of nodules on the face, and these nodules are coalescing together, and this is giving a lion-like appearance to the face. This kind of appearance is called as leonine facies, and it is characteristic of lepromatous leprosy. Moving ahead, this right here that you see is the Ridley-Joplin classification of leprosy. So in the Ridley-Joplin classification, we have a TT, tuberculoid pole. We have a BT, borderline tuberculoid, BB, mid borderline, BL, borderline lepromatous, and LL, polar lepromatous. So how is this classification achieved? Basically, this classification is basically the response of our body to the M. leprae. So an individual which is infected with the M. leprae is able to either mount a good cell-mediated immune response or a poor cell-mediated immune response. When the individual mounts a high cell-mediated immune response and a primarily Th1-mediated immune response, it is known as the tuberculoid pole. So here, the individual is mounting a very good immune response. As a result, the bacteria are killed primarily due to the Th1 immune response, where free radicals are produced, and there is a localized infection. Infection does not get disseminated and does not spread. And you have few M. leprae. When you do the slit skin smear, you hardly see any M. leprae. It is a localized disease, and it is primarily slit skin smear negative. Whereas the other pole is the lepromatous pole. This pole is the one where there is low cell mediated immunity. It is a Th2 immune response. Here there is sustenance of infections. The macrophages are infected with M. leprae and there is no such thing there that can help to kill it. So these M. leprae are infected in the macrophages, and these macrophages stay and they form granuloma, which are macrophage granuloma, and they disseminate here and there. So there are many M. leprae. It will be smear positive. So the range of clinical manifestations depends on the strength of the CMI response. A tuberculoid pole, which is the tuberculoid leprosy, as I told you, is the least severe form. It is self-limited, and it is limited by an intact cell-mediated immune response. There is a Th1 immune response where there is production of interferon gamma, and there is production of free radicals that help to kill and contain the infection. There are mild skin plaques, and it is associated with hypopigmentation, which is the cardinal sign. There is hair follicle loss, and there is focally decreased sensation. And the other pole is the lepromatous leprosy. It is the most severe form, and it occurs in patients who generate a weak response. It is Th2 mediated. Macrophage signaling to kill M. leprae is limited, leading to mycobacterial dissemination. Important word is that there is dissemination. Manifestations include diffuse skin thickening, plaque-like hypopigmentation, hair loss, leonine facies, paresis, regional anesthesia, testicular destruction, and blindness. So moving to the second option in the question was Borrelia burgdorferi. So Borrelia burgdorferi causes what? It causes Lyme disease. So Lyme disease is a disease in which there is characteristic skin rash that you see here in the image. It is called erythema chronicum migrans. So it is an annular skin rash. You see there are annular macules. The central macule, and then a surrounding area which is hypopigmented, and then there is another macule, erythematous macule. So this is erythema chronicum migrans. Also there is presence of fever and malaise. There is characteristic presence of arthritis, facial paresis, and cardiac involvement can occur in the form of conduction abnormalities. Prolonged untreated disease can lead to central nervous system involvement. Moving to the third option, Corynebacterium diphtheriae, as you know, is a gram-positive rod, and it causes diphtheria. It is a primarily toxin-mediated lower respiratory infection that is complicated by polyneuritis and myocarditis. Here, and the fourth option that we had was Treponema pallidum. So Treponema pallidum causes a disease which is syphilis, which is a sexually transmitted infection. It manifests initially as primary syphilis. Then the other manifestations are secondary syphilis and tertiary syphilis. So primary syphilis manifests as a hard chancre that you see here in the image. It manifests as a painless indurated chancre at the inoculation site. Secondary syphilis results in erythematous macules in the entire body, and most importantly on the palms and soles, which are sites that must be seen, and it causes condyloma lata. Condyloma lata is the infection of the mucosa. Okay, it is the infection of the mucosa. The images are in the next slide. Tertiary syphilis results in skin and bone gummas and ascending aortitis. So you see these are pictures of secondary syphilis. You would see maculopapular rash on the body, And you would see palm and sole involvement. You see these small lesions on the palms and soles. These are manifestations of secondary syphilis. This is condyloma lata, which is basically when there is involvement of the mucosa in the secondary syphilis. These condyloma lata are basically lesions which have a broad base, flat top. They are very soft and they are very infectious lesions. Tertiary syphilis manifests as gumma, which is basically a punched out ulcer with a washed leather slope that you see in this image. So in tertiary syphilis, you would see skin gummas, you would see bone gummas, you would see cardiovascular syphilis in the form of aortitis, and you would see neurosyphilis. Meningeal involvement, parenchymal involvement can be seen in neurosyphilis. So, what was the educational objective of this question? Educational objective is to know that how would you diagnose leprosy. Leprosy is diagnosed when you see there is involvement of the skin in the form of hypopigmented, hypoaesthetic macules, presence of thickened nerves, and a positive slit skin smear. So, leprosy is a chronic granulomatous disease which infects skin and nerves, the two main sites. It presents with hypopigmented, hypoaesthetic patches, thickened nerves, and then it depends on the host's immune response, what spectrum that the leprosy is in. A good cell-mediated immune response manifests as tuberculoid leprosy, and a poor cell-mediated immune response manifests as lepromatous leprosy.